Use of miniaturized endoscopic equipment, that is 2.7 millimeter scopes with 3.5 millimeter outer sheet, to directly visualize the uterine cavity without the need of formal theater facilities or general or regional anesthesia. Advances in the endoscopic technology and instrumentation have allowed operative hysteroscopic procedure to be done in the office. As everybody knows, there are advances in the technology which are occurring. You can see the computers and laptop like that. The first hysteroscope which was there has now become an office hysteroscope. The OR has been converted to an office hysteroscope. So are we justified to do all these hysteroscopies? Yes, because of the only single idea that changed everything. Internal os is oval and not circular. Thank you to Dr. Bertocci, who has brought this concept, and that is why the shape of hysteroscopes has changed and office hysteroscopy is so familiar with everybody today. There are benefits like a reduced cost as compared to the conventional hysteroscope. As everybody knows, in a corporate hospital, 1 day stay of IPD is too much, and in that cost, we can do an office hysteroscope. There is higher patient satisfaction rate has been proven by all studies, and lower complication rate because patient is totally awake, and if you are going into a different plane, patient is going to have pain and you're going to stop the procedure there and there. The faster recovery because patient goes home in 2 to 3 hours time, and there are better results. Why it is getting popularized? Because we are doing pre-IVF hysteroscopy for
Sir, can you hear us?
office hysteroscopy. And mostly it has become a gold standard in Asherman syndrome, which you are going to see in the future slides. Unfit patients and oncological follow-up. Those patients who have cardiorespiratory problems, kidney diseases, who have not been fit for anesthesia, these are the patients which can be very well managed with the office hysteroscopy. Those patients who are virgin patients, office hysteroscopy is going to be a judicious decision for these girls. And pediatric age group, there are so many incidences where a mistaken foreign body has been put into the vagina, and that can be removed without hassle, without anesthesia by office hysteroscopy. There are definitive indications, and 90% of the hysteroscopies can be done by office hysteroscopy nowadays. So diagnostic hysteroscopy, intrauterine adagiolysis, removal of retained products, endometrial polypectomy, removal of small submucous fibroid G0 and G1, endometrial ablation, and removal of lost intrauterine devices, and transcervical sterilization, and even a metal metroplasty can be done with the scissors. There are certain myths for the patients. Ambulatory hysteroscopy procedure performed without anesthesia, maybe it is very painful for me, doctor, or the cost of replacing your previous instrumentation and taking this might be costly, so office hysteroscopy must be very costly. But no, it minimizes the discomfort and pain related to the outpatient procedures, and the cost is less than 50% than the previous cost of IPD hysteroscopy. The most important approach is pain-free approach, which has been a best approach for the patient, and that is why it has become a popular. A comfortable chair and positioning, no IV lines for the patient. The room should be having good ambience. You should be talking to the patients continuously. You should ask about their social history, family history, their educational history, and everything. And a small music being around is going to give her that comfort which is at her OPD procedure. And the most important is the vaginoscopic approach. So avoiding speculums, valsellum, tenaculums is going to make it a pain-free approach. Avoid touching the labia of the patient. So very important is the respect the uterine physiology. The correct intrauterine pressure should not go beyond 60 millimeters of mercury, and do not touch the myometrium. That is going to be a key of pain-free approach. As you can see, if it is a distended uterine cavity, the muscle fibers will be in aligned position. But if pressure goes beyond 60 to 70 millimeters of mercury, then these fibers are stretch, and that is why a pain will stimulus will go to the patient, and that is how the key of the procedure is not to over distend the patient. The appropriate surgical technique allied to the pain control, allowing office hysteroscopy to resolve more than 90% of the patient. The most important is avoidable mistake is through office hysteroscopy. If you are doing under anesthesia, if uterus is acutely retroverted or acutely anteverted, you can mistakenly perforate this uterus, but here you are doing it at a vaginoscopic approach. Patient is not sedated, that is why this mistake can be avoided. As everybody knows, it is done in an OPD procedure and formal operation theater is not required, and there can be a multi-purpose facility suite available for this patient with a toilet facility with vocal anesthesia. That means you are talking to the patient. The distension medium usually is a uterine distension with normal saline, is comfortable, quicker and cost effective, and provides superior view in cases of intrauterine bleeding. Furthermore, vaginoscopic approach is much easier with this, and if operative is required, you can use bipolar electrosurgery, which is important. Instrumentation, everybody knows the Bertocchi's hysteroscope allows micro scissor, grasping forceps, and 2.9, also 2.7 millimeters. Small 16 French instruments and receptoscope which are available can be used, and the newer mechanical tissue morcellators also allow quick office hysteroscopic procedures without the need of long-lasting curve of learning for the beginners. That is the biggest advantage of office hysteroscopy. The vaginoscopy, that is no-touch technique for the automatic insertion of the hysteroscope into the external os without the aid of speculum or tenaculum, is directly into the vaginal cavity, and that is why it is very important that there is no pain for this patient. The first important is the alignment of your scope. So you can see this is an office hysteroscope. First, align the office hysteroscope, and then do the white balancing, and then start vaginoscopy procedure. As here you can see, patient is awake after doing a white balancing. You are going to put this into the posterior fornix. Once you are putting this into the posterior fornix, you are going to see, until you see an external os, you are going to start doing this procedure. Once you are seen the external os, you go inside the uterine cavity, and everybody is into this procedure. Even anesthetist or your assistant are going to talking to the patient, and you are going to talk to the patient, and cervical preparations are not needed for this. The vaginoscopic approach is same, that is go into the posterior fornix. After going inside the cervical canal, move forward into the uterine cavity, try to be in the midline, don't touch here and there, and main trick to reduce the possible trauma is to maintain the scope located in the middle of the canal and avoiding stimulation of the muscle fiber. Until you see a black hollow, that is internal os, you are going to go inside the uterine cavity. There are certain problems like a cervical stenosis, which can be managed by using scissors during this procedure. There can be a cervical stenosis because of the nulliparity, postmenopausal status, fibrosis, repeated abortions, and this can be very well managed by using a scissors, and you can cut these adhesions by using a sharp scissors. Also here patient is awake. If you are going into another cavity or abnormal cavity, the patient is going to tell you where if there is a pain, if you are going to a wrong place. And you can do the same procedure with a grasper forceps, that is you are going to open the internal os if there is a problem. And in certain desperate conditions, if there is a problem, then you can use a loop excision at the level of the internal os, and you can cut the excess tissue, and you can negotiate the cervical tissue. So you can, with office hysteroscope.
Sir, sorry to interrupt, sir. 2 minutes left. 2 minutes left.
You can do the procedures of removing the small polyps through the office hysteroscope. You can remove the large polyp through the office hysteroscope by using a grasper forceps or using scissors also. So all these procedures, which are office hysteroscopy procedures, can be done with the office hysteroscope. Also, cervical fibroid, which can be removed by office hysteroscopy. And I would like to show this video by Dr. Harish Vagasia, where OPM, office preparation of the myoma, where this procedure first was described by last month. You're going to cut around the fibroid into the pseudo capsule, and you're going to make the fibroid free of the pseudo capsule. And once you are done that, the fibroid is totally free, and you can put a grasp for forceps to remove this fibroid. So this procedure of removing even G2 fibroids, which are smaller, can be done with the office hysteroscopy if you are going to do. And the last is most important is the Asherman's, where you can use the scissors. And the best advantage is patient would allow division of all adhesion bands which are non-innervated. And when you cut the myometrium, it will cause pain. That is indicating that you are going into a wrong pain. So the biggest advantage of office hysteroscopy is in a cases of Asherman syndrome. And here, a lower part of cervical adhesions, if you cut properly with the scissors, the patient is going to allow to do this procedure because it is a pain-free procedure, and you can do it very easily.
Sir, time's up. Time's up.
Septum can be done with the scissors or bipolars, as Judge rushed. Bony spicules can be removed with the office hysteroscope, and even a copper T, which is
Kalyan, the time is up.
Yes, sir. Missing copper T can be removed with the office hysteroscope. The latest buzz is periscope, cryoprobe, and endoscopy system. To conclude, it has a reduced cost as compared to the conventional hysteroscopy, higher patient satisfaction rate,
Good morning.
and faster recovery, giving the best results. I'm really thankful to team IAGE for giving me this opportunity. Thank you so much.